Two, one. We can start.
So, good evening, everyone, and welcome to yet another class by Dr. Abha. And today's very interesting topic that we are going to hear from her is how does she choose her gonadotropin for the IVF cycles? Ma'am, over to you.
Thank you, Tejashree, for getting me into this. And every time it is good that I get to read a little bit. And these topics are like of real interest to all of us, and hence it is there. Now we are talking, I know that IVF people would be more interested in this talk today. So how do I choose my gonadotropin for IVF? And this is not only my choice, but this is evidence-based and I follow it also. So what are the gonadotropins which we need to choose from? One is follicular stimulating hormone and the other one is luteinizing hormone. So if you say, oh ma'am, you've not brought in HMG here. Well, HMG is a combination of these two hormones, though it is extracted from urine and it has a little HCG also. So evidence does say that HMG works well, but somehow in our country, the bioavailability of HMG is very different from batch to batch, from ampule to ampule. So when I talk of follicular stimulating hormone and luteinizing hormone, I intend to restrict myself to recombinant preparations. Now, we all understand that both LH and FSH are essential for follicular development. And if you see, it is FSH, which is the first one to initiate follicular growth. After 6-7 days, it has to come down so that only one dominant follicle continues to grow and LH starts rising. And in response to these, the ovarian steroids also form. And the two-cell, two-gonadotropin concept, you all know very well that there are two gonadotropins, LH and FSH, which is very important for folliculogenesis and steroidogenesis. Now, regarding LH, I just thought that you must know the role of LH in early follicular phase and in mid-follicular phase. In early follicular phase, LH comes from theca cells and it increases androgen synthesis, which gets converted under the effect of FSH into estrogen. And it also helps stimulate follicular recruitment. So this is the work of LH in the beginning, that it will increase androgen synthesis and it will also help in follicular recruitment. Whereas in the mid-follicular phase, LH increases estrogen synthesis. That means steroidogenesis and stimulates follicular growth. Having said that, I also want you to let you know that LH levels vary throughout a normal menstrual cycle. And you have seen here that first FSH is high, LH is low, FSH comes down, then LH starts going up, peaks at ovulation, and then is maintained in the luteal phase for implantation. So if LH is below this level where it is, if it is here, suppose, estradiol levels will be inadequate for endometrial proliferation as well as steroidogenesis and hence corpus luteum formation and its function. And what is required of LH? Less than 1% of follicular LH receptors need to be occupied. So out of 100 receptors, if even one receptor is occupied, we will have maximal steroidogenic response. This is very important for all of us to understand. Having said that, what did we know? What we knew about role of FSH and LH in an ovulatory cycle is FSH is supposed to stimulate follicular growth in the proliferative phase of the cycle. LH is supposed to luteinize the granulosa cells and secrete progesterone in the secretory phase of the cycle. What we learned later on, that a small amount of LH is also needed for estrogen synthesis in the later part of proliferative phase of the cycle. So LH helps in progesterone secretion in the luteal phase and estrogen secretion in the proliferative phase. This is a very important learning which we all have come to know. So what is our patients who always boggle us? One is a group of patients where LH-FSH is very, very low for whatever reasons. One is patients of advanced stage, and another one is patients with low ovarian reserve. Rest of them don't bother us. Those who have normal reserve, young age, we don't bother. Those who have high reserve, young age, we don't bother. So these are the three groups where we are always thinking, what stimulation should we give that we get adequate response. So let us talk about patients with LH, FSH deficiency. There are two types of deficiency. One is congenital and one is acquired. Congenital deficiency, you all know, is the hypogonadotropic hypogonadotropin patient. And here, if you see clinical outcomes, when we give FSH plus LH, we use HMG. Whatever we use in both, we will get pregnancy and dominant follicle. On the other hand, here, if you see, if we use HMG, these are the total number of pregnancies, the one in dark violet. When we use recombinant for the same group, then the pregnancy rate increases a little bit. It goes higher. So out of lesser patients, we get higher pregnancy. More than half are pregnant here, a small number. So HMG does have its drawback that it is urinary derivative and it is not batch to batch stable. Now we come to another congenital deficiency, which we've recognized very recently for the last 10, 15 years only. That is polymorphism of gonadotropin variant LH beta. Now, there is a variant LH beta, which is homozygotes, heterozygotes, and wild type. Wild is considered normal. Wild is considered normal. Can you mute all the audience, please? Can you mute
Dr.
the
Deepika,
audience?
request you to mute yourself.
They could be homozygotes and they could be heterozygotes. And the FSH dose, if you see on the side, increases with the homozygosity. See, if you are a carrier or you have complete variation in the LH beta genotype. When there is a lot of difference, you need a really high dose of FSH, more than 3,000 units as total dose to stimulate. But when you have a little bit of normal, little bit of mutation, that is heterozygotes, then you use about 2,000 units. And when it is absolutely normal, you use even lower. So all the carriers have high FSH consumption. And the higher is the variation polymorphism, the higher would be the need of either we compensate with adding more FSH or we add LH to these women. I'll show you here. Now, we know that this is a new definition of saying that FOI is a new marker of efficacy of stimulation. Normal FOI means this is the cohort and this is the number of oocytes generated. This is the cohort and this is the number of oocytes generated. So this is normal. But if this is the cohort and only this is the number of oocytes generated, or from this is generated, this is low FOI, follicle to oocyte index. And this is most common with either we have started a low gonadotropin starting dose with whatever reasons, or there has been asynchronous follicular development, or there has been FSH and LH polymorphism, the variant LH beta. So if this is present, then these patients will respond to a so-called adequate dose also, synchronous development of follicles also, the response will be less. And the last we know for a low FOI is that trigger problems or technical reasons for oocyte pickup also may lead to less number of egg pickup. Having said that, how do we manage low FOI? One is you increase FSH dose in the next cycle. Number two is you add LH. So when we look at this, LH supplementation on day 7 to 10 versus increasing FSH dose. So you've seen a patient, you stimulated her with FSH, and after 5 days, you called her for a ultrasound and a estradiol estimation. And then in both of them, you found that the stimulation is not like what I expected it to be. On one hand, you increase the FSH dose. On the other hand, you started LH supplementation. And you find that if you look at the pregnancy rate, LH supplementation really helps more than just increasing the FSH dose. And it is very important that if you are using 300 units of FSH already, then 150 units of LH is more effective than just giving 75 international units of LH. However, you have to remember that only 1% of LH receptors are enough for steroidogenesis as well as follicular recruitment also. Such people in the next cycle always start LH right from the beginning because it takes care again not only in estrogen synthesis, in androgen synthesis, but also in recruitment of follicles. So look at the difference that, you increase the FSH dose and here you added LH from day 6 onwards. Now, what is an acquired deficiency of deficiency of FSH and LH, the pituitary gonadotropins? What do we use? We use GnRH analogs. What are the two analogs we use? Agonist and antagonist. This is what we use to suppress LH. But can you suppress LH alone? No. You will suppress both the hormones because all these agonist and antagonist work on the receptors to suppress both the hormones together. So this is the natural pulsatile GnRH, this is the agonist, and this is the antagonist. And if you see, antagonist will suppress within hours. Agonist takes a few days to suppress because it will cause a flare and then suppression. And the pulsatile one is pulsatile, so it helps in production all the while. Having said that, when we use a natural cycle, then this is the serum LH concentration. The moment we go to an antagonist cycle, this is what the suppression goes, and then it continues to over 1 IU per liter. We use agonist long protocol. The suppression is generally much higher, and the levels go below 1 IU per liter. So it goes on by HCG day, they are the lowest. So this is what happens by the two analogs which we use in all IVF cycles with the aim to suppress LH. It suppresses LH quite a bit. So this is a acquired deficiency of FSH and LH. Now, I want to remove this bar from here. How do I? Okay, acha, now it's gone. Now, what is the effect of different ovarian stimulation medications on cumulative live birth in patients with LH oversuppression after pituitary downregulation with GnRH agonist? This is a single center retrospective study, and it is a propensity score match study, which means, and this was presented as a poster in ASRM 2019. Later on, it was published as a paper. So you see increase in cumulative live birth with recombinant human FSH and recombinant human LH compared to urinary HMG. This is urinary HMG, only FSH, FSH plus SH, LH. So the sort of cumulative live birth goes on increasing when we add recombinant LH in the ratio of 2:1. So cycles in which LH was suppressed by more than 50% on stimulation as compared to baseline. So here they picked up those cases where whatever baseline LH was there, if after 5 days of giving gonadotropin, that is FSH, they found that LH was suppressed more than 50%. They were picked up for this study, and they did 3 things if you see over here. A recombinant FSH alone, HMG alone were matched, and then they also got to see when LH was added here. So this is how they did the study, and they found that if they added LH, they got the highest number of cumulative pregnancies. Now, clinical effect of a natural extract of urinary human menopausal gonadotropin in normogonadotropic infertile patients. Now, purified human menopausal gonadotropin is a natural product extract from the urine of postmenopausal women that contain pituitary, follicle stimulating hormone, luteinizing hormone, and a small amount of human chorionic gonadotropin also. And if you see that, just a minute, yeah. So here they conducted a clinical pharmaceutical study on a cohort of normogonadotropic infertile patients, which were addressed to long GnRH agonist protocol with serum LH concentrations ranging from 0.5 IU to 1.5 during mid-follicular phase, aiming at evaluating the effect of purified HMG supplementation during ovarian stimulation. And But what did they find? We say that, okay, we can give HMG instead of LH. LH is more expensive. And this is a Chinese study. This is not the group where Merck and Serono company are sort of supporting them. So we suppose that exogenous LH supplementation is not needed when serum LH concentration in the mid-follicular phase is around 0.5 to 1.5 during the long GnRH agonist protocol. And adding exogenous HMG may decrease the fertilization rate and increase the risk of developing OHSS. They say that instead of LH, if you want to add HMG, it decreases the fertilization rate. So this paper got this information. They came to this conclusion that adding exogenous HMG is not as good as adding LH supplementation directly. And the explanation for this is that there are no receptors for HCG, which HMG contains, but there are receptors for LH and FSH. And hence, HCG's activity to quite an extent is because of the HCG molecule in it. So the gist is, what I would want to tell you is that in patients where we think that in the long agonist protocol, the LH levels have dropped drastically, it may be a good option to add LH in the proportion of 2:1 with the FSH from day 7 or day 6, whenever you call the patient, after 5 days of stimulation. And in hypo patients, you have to give LH, FSH both. And you've seen that the recombinant works better than HMG. And in polymorphism, also you've seen that adding LH is going to help us more than just increasing the dose of FSH. In all three circumstances, LH tends to fare better than patients of advanced age. So what are the reasons that we see that in advanced age, what happens to the oocyte quality? Why are we so worried? It is the mitochondria. And all therapies are sort of aimed to enrich the mitochondria of aging women. Mitochondrial function is impaired in quality, granulosa cell apoptosis increases, again quality goes down, and oxidative stress increases, also that leads to lower quality. So mitochondria viability per age group, if you see less than 35 years and more than 35 years, there is a significant difference in mitochondrial viability in women less than 35 and more than 35. Now you look at androgens. At a certain age, when estrogens start getting less, the woman is aging, sex hormone binding globulin is equal as age and time in years. You see, from 20 to 80 years, sex hormone binding globulin doesn't. But from 16 years to 65 years, you will see total testosterone going down, DHEAs going down, androstenedione going down, and free testosterone going down. So all the androgen goes down. So when women come in this age group for conception, the androgen is already receding. And that is why androgen is thought to be a very important hormone in probably bringing back the sensitivity of the follicles. So androgen and folliculogenesis. Is folliculogenesis all about androgens? Well, FSH receptor induction on granulosa cell increases the responsiveness of the granulosa cell, and this acts synergistically with IGF-1 growth. Increase in pre-antral and antral follicles, recruitability also increases. And this has been seen in a lot of studies now since last 20 years, where androgen patches are given in the initial phase or one cycle early, but it is a small androgen dose which is important because they've got an antagonist activity. If you give a high androgen dose, then it will suppress follicular formation because all this androgen will not be able to be converted into estrogen by the aromatase enzyme system, and hence the follicular growth stops and atresia happens. But if it is in a very small dose, which can be processed by the aromatase enzyme system, then it will increase estrogen synthesis, follicular growth, and recruitment, everything. This is a very important chart which I ask all my PGs to see. This is the ART calculator for Poseidon group patients, and how many mean number of oocytes are needed to generate one euploid blastocyst. At an age less than 35, around 6 oocyte cumulus complexes are good enough to generate one euploid blastocyst because euploidy rate is more than 60%. Between 39 to 40, I mean, up to 40, you need 10 COCs because euploidy rate drops to half, that is 30%. And once a woman is more than 42 years old, then you need at least 16 COCs to generate one blastocyst. And this is when fertilization rate is adequate. 10 first fertilized oocytes, you make 5 blastocysts, then you say that you will have one euploid because 20%. If you have 3 blastocysts in the age of more than 35 to 40, then you will say that euploidy rate is 30%. So you will need at least 3 blastocysts to make one euploid blastocyst. And when you come to a younger age, then just 2 blastocysts, one will be euploid out of them. Definitely, both could be also euploid. So this is a very important chart for all of us to remember. Looking at age, how many blastocysts we need to say what is the proportion of euploid to aneuploid blastocyst here. Cumulative live birth rate and number of oocytes retrieved in aging patients. This is an analysis of 4,500 cycles. The red line is of 38 to 39, green line is 40 to 41, blue line is 42 to 43, and then more than 43. So you can see live birth probability goes on falling as age goes up. And whatever oocytes you retrieve, 4 oocytes, 8 oocytes, or 12 oocytes, the probability after 44 is very, very little. I mean, the probability after 12 oocytes is just about 2% of reaching a live birth. So we have to understand age is a very, very, very important denominator. And we need more and more oocytes, more and more blastocysts as age increases. Now, what happens when we do LH supplementation in women who are between 35 to 39 years? Most of the studies here on this forest plot shows that the moment we add LH, the diamond shifts to the right. So we get more clinical pregnancy rates, high monotherapy in ovarian stimulation. Now we come to the last group, patients with low ovarian reserve. In low ovarian reserve, this is a PROSPER model, which is known as Poor Responder Outcome Prediction Model. And this was based on the Bologna criteria. Whereas what is important over here, that if a patient has 0 score is the best, has 1, it is worse. And if it has 2 score, it is the worst. And with the 2 score, she's more than 40 years. And her number of oocytes retrieved in the previous treatment cycle are less than 2. Or she's more than 40 years and she's not had a previous retrieval, her AMH is less than 0.5. So there you give her 2 score. Here it is either of the two things. Either she's more than 40 years or her AMH is less than 5. One of the two things must be there. And here both the things are all right, that she's less than 40 and her AMH is more than 0.5, then she gets a 0 score. So what is PROSPER and what is this prediction model? Patients who get a score of 0, if none of the factors apply to them, a score of 1, if one of the factors apply to them, and score of 2, like I explained, if they meet both the factors. The live birth rate is determined based on the live birth rate for poor ovarian responders observed at the center during a previous year and the proportion of patients classified as PROSPER score 0, 1, 2 in the previous year. The live birth rate decreases by a factor of 3 with each factor met. So it is a score which is designed specifically for poor ovarian responders treated with FSH to identify subpopulations according to live birth outcomes based on the number of factors, which are these. All I want to say is that they are looking at we are looking at poor responder women who come into this group due to age or due to the number of oocytes received or the AMH, which is low. And according to this PROSPER score prediction model, sorry about this, Prosper score prediction model. We look at this and then we know that which of the patients which will be poor responders when we treat them with only FSH, or we need to add something more. And they have looked at efficacy and safety of FSH in ART, a randomized controlled trial, and poor ovarian responders. They took about 1,000 patients. In one, they gave fixed dose of 300 IU of FSH plus 150 IU of LH. In the other group, they gave FSH 300 IU monotherapy. And they found no difference in oocyte number. And their basic severity score was mild, moderate, severe according to Prosper. But higher live birth rate when they gave the combination of FSH LH in moderate and severe POR. So mild doesn't matter whether you can get away with just giving FSH, but if there is severe or moderate score for POR, poor ovarian reserve, compared to mild, then there is higher birth rate, live birth rate if we add LH, and lower pregnancy loss rate also in this group. So there is an effect of adding LH in this group, not only on the number of oocytes, but it is on the embryo formation and endometrium also. Now here again, you find the same. I've given this predicted value of live birth. This is control, the red cycle. And this is blue one is where we have treated mild, moderate, severe POR. And you see the moment you add LH versus FSH only, you find that this is FSH only. Control is this one where only FSH is there, and the blue line is where LH is there. The line goes up. In mild, it doesn't show any difference, but in moderate and severe groups, the live birth rate goes up significantly the moment we add LH to these cycles. So LH versus HCG, here I just wanted to bring a little bit that LH has a lower half-life, 6 to 10 hours, and HCG has a 48 hours half-life. So LH does not accumulate in serum, and there is no downregulation of LH receptor because the half-life is less. It just leaves the receptor, and when you give next day a dose of LH, it will again act on the receptor, whereas HCG sticks to the receptor to whatever extent it occupies the LH receptor. It keeps on being there for 48 hours. And that is why LH and FSH will have an anti-apoptotic effect, and HCG and FSH together, which is contained in HMG, will have a pro-apoptotic effect. Having said that, the conclusion is LH supplementation will benefit patients with congenital LH FSH deficiency. We all agree 100%. In genetic polymorphism, it is LH addition which will help more than increasing the FSH dose. And with patients with acquired LH FSH deficiency, such as pituitary suppression regimens for IVF, also might help if LH suppression is a lot, especially in the long agonist protocol. Patients of advanced age, we have seen, is an additional group who seem to benefit, not only when we add LH right from the beginning, but even after we add LH after 5 days of stimulation. And again, patients with low ovarian reserve where the mitochondrial function goes down, LH does improve the androgen accumulation, synthesis, conversion, growth hormone, and growth factor to follicular recruitment. So we can go exactly with the concept of heavy and light. FSH is light, and FSH and LH is heavier. It's more expensive, it is more hormones, and it is more expensive. Light is very good if maternal age is less and there is normal or high ovarian reserve. But when the patient comes with heavy problems like advanced maternal age or poor ovarian response, or there is a receptor deficiency or polymorphism, these are heavy problems and we need heavy treatment for that. We have to add LH over here, whereas for the lighter ones, we can just use FSH and it works wonderfully. Thank you very much.
Thank you, ma'am. Thank you. It was a quite insightful lecture, and I think the new thing that I learned today is about the HCG thing, which I've always kept on thinking that when it acts as a surrogate for LH in all other situations, why not can we use it during stimulation cycle? So that was very clear that why we can't use a small dose of HCG as a source of LH during the ovarian stimulation.
Yeah, that is why I brought that slide, that as a trigger, we want it to be long acting.
Absolutely.
Because
That
we
is,
want to keep the corpus luteum alive.
yeah,
But here,
because
when we use it on a daily basis, then it accumulates and it occupies the LH receptor. And further on, as we go on giving HCG on a daily dose, it has no receptor
no
to act.
receptors to act on. Right. Ma'am, again, one thing that I wanted you to clarify is that you would clearly prefer a recombinant source of LH rather than HMG,
See,
wherever
Tejas, I
patient
have
is.
been practicing IVF since 1990. I started my practice with Metrodin injection, which was a Merck Serono product, and it was a urinary FSH. And at that time, we were happy with urinary FSH. Somewhere around 2004 and 5, we suddenly found very inconsistent results by using urinary FSH and urinary HMG both. And probably the explanation which I asked, we suddenly found that no patient was responding. 5 days of good doses of gonadotropin, and those days we used to use 225 mostly, 300 less often. But we never had such a lot of poor responders and advanced age women at that time. So HMG just stopped working. Urinary FSH stopped working. And then all this theory came out that, first this supply was coming from Netherlands and it went to China. But China is doing a lot of work in reproductive medicine. I don't believe that it is only this reason that urinary products are less effective. It is truly this, that, the standardization of urinary products, they normally say 75 units can either contain as little as 30 units of FSH or as much as 110 units of FSH. So when you're giving 75, you don't know what you're giving. Are you giving 35 units on a daily basis? When you're giving 225, are you giving just about 100 units on a daily basis? The biological availability has become very questionable. And earlier, IVF took a minuscule part of reproductive medicine in the in the 80s, 90s, and the early 200s. Now it is massive. That supply cannot be met by the urinary gonadotropins which are being extracted. Recombinant has become a must, and recombinant
Right.
has a much more stable bioavailability. The prices are comparable. All over
Right.
Europe and America, both the gonadotropins are equally priced. Only in our country, we get urinary cheaper, but then there are some urinary products which I have seen. A young donor coming from America was taking 1,200 units of a urinary gonadotropin on a daily basis. And I said, you will
Oh.
die. And
Hmm.
on the contrary, the consultant called me and said, we got only A two sites from her. What is this? Tell me.
Hmm.
Are we not using water in the name of gonadotropin? So this is the problem with it. Otherwise, I have full faith on urinary gonadotropins. When I make endometrium, I always ask for urinary gonadotropin because my aim is not to stimulate an egg or get a good quality oocyte or a pregnancy. I just want to stimulate the endometrium. So this is my, you would say, bias towards recombinant, because it is my own experience that 30, 40 cycles of my went right into water those days. I mean, for
Right.
almost 45 cycles, we didn't get enough oocytes and we got no pregnancies. It was an eye-opener when we all thought what could be the reason, and then we changed over to recombinant.
Your
So this is
experience is
my take
always the
on it.
learning
It is
point for all of us,
personal
ma'am.
experience I'm giving you. And
Absolutely.
I'm sure all of you will observe this. If you stick to urinary, it does work, but not from all companies and all
Yeah.
products and all.
Dr. Raheen wanted to, I think that answers, your explanation answers very well Dr. Raheen's question, where she was asking about recombinant FSH and recombinant LH versus RFSH and HMG in poor responders. So that answers her question, ma'am.
RFSH
We
and
have
HMG. Yeah.
we have more
HMG, you see, I
questions.
told you studies. I had no way to convince, but I have been able to be convinced myself that there is no
Right.
price difference. If you really are honest to your patients and you can give them subsidized, there is so much difference between the price in which you get the injection and what the MRP is, that if you can get it at a lower price to your patients, I mean, they don't mind a price of spending a few thousands extra in order to get a pregnancy rather than buying a drug which is not giving the response which you desire. I've seen all of you using 400 and 450 units of HMG.
Right.
Still, I get cases where they say no oocyte retrieved, and we use just recombinant FSH. Tejashree sees this
Yes.
day and night, and we get 8, 10 oocytes making nice, good embryos. So somewhere the HMG is not correct. That is
Yeah,
what is troubling me. It is not your choice of
batch to
HMG.
batch
You go
variability is
out,
quite significant.
you go out, buy it abroad. I don't know how it would be there because I've never bought it outside, but I know Progenova from outside works beautifully, but Progenova from our country doesn't work. And it
Yeah,
is
we've
from
seen that
here,
quite
which is a
often.
very good company.
Yeah.
So what is
Ma'am, we
happening
have more questions coming up in the chat box.
here?
Two of our doctors, Dr. Mrinal and Dr. Sophia, wanted to know whether there is any test to assess the FSH LH polymorphism
Yeah, there
receptor
was a very beautiful slide which I omitted, which I had on FSH. Like you see, we were looking for a test for ovarian marker, and suddenly around 2004, 5, 6, AMH was discovered. This new molecule and new test came in. In the beginning, hardly we used to be able to do AMH because it appeared as a very costly test. LH, FSH estimation would cost us 250 or 300 rupees, and AMH was 3,000. And there was a lot of inconsistency. Same way for polymorphism also, they are trying to detect test, but till then, you can understand that if you used an adequate dose of recombinant gonadotropin and you were airtight everywhere, that means you did a good trigger, you did a good aspiration, and you used adequate dose, that means 300 units in a patient who had a normal reserve type of a thing, or maybe normal to low, and you got a very poor response. Like I got in one patient today. I got just 3 oocytes, and we used a lower dose thinking that her AMH is high, but then when we revised, we thought we should have repeated her AMH. We got only 3 oocytes because I used 200 units of FSH for her. And we did not increase because after 5 days, her E2 from 53 went up to 438. So we kept going with the same dose. Though there were 6, 7 follicles, we recovered only 3 oocytes. So here could be receptor polymorphism, maybe for this. And we looked at her LH. On day 7, the LH was 13. So the levels of LH were not low. But polymorphism doesn't say that LH levels will be high, there'll be no polymorphism. So if there is a test, we will get it in near future, and I'm sure we will get one for polymorphism. But right now, if your FOI is very low and you feel you've used adequate dose and you've done a proper AFC and AMH estimation, then this is a case who could be having underlying polymorphism. In the next cycle, treat her with this thought in mind.
Right, ma'am. Ma'am, what is your gonadotropin of choice for COS and PCOS patients? Dr. Harita wants to know.
For ovulation induction?
Yes.
Asking controlled
IVF.
stimulation is done for IVF. Also for PCOS, Harita, I have switched over completely to recombinant gonadotropin, and all doctors working with me, Tejashree is with me for so many years, and Dr. Bhavani is one of your 2 moderators is there. I use exactly what I say, and I use only recombinant gonadotropins, whether they are biosimilars or they are made by the monoclonal process.
Ma'am, Dr. Yukti wants to know what is the importance of pro or anti-apoptotic effects of HCG and LH respectively.
You see, apoptosis is destruction of cells. So pro-apoptosis is not what we want. We want anti-apoptosis, right, Yukti? So HCG has a pro-apoptotic effect. I showed you in the slide little earlier. You see here, pro-apoptotic is from HCG and LH-FSH is anti-apoptotic. Apoptosis means a natural cell death.
Ma'am, how do we predict and prevent premature progesterone rise with recombinant FSH?
If your stimulation is too heavy, it would rise. That is the only explanation, because if you were giving very heavy stimulation in a PCOS patient and then the progesterone rises, So you can't predict it. You can only test it and see. And if it has risen, then you can think whether you want to cancel a fresh transfer or you want to go ahead with fresh transfer. But if the stimulation is very strong and the E2 levels go up a lot, progesterone also tends to rise in such cases.
Ma'am, Dr. Nisha is
That-
saying that what is the gonadotropin of choice in positron 1 and 2? Because whenever I've used 2:1, I have eventually converted to HMG always.
Well, when I use well, Luveris, when I give, it is only 75, but in women who really, this is Poseidon 1 and 2, means a normal reserve, right, Nisha? Normal reserve, but poor response. Here, you have to see that whether you've started with the right dose. And if the dose was right, then if you think that there's polymorphism, then you will use LH. I normally, when I add Luveris, it is only 75 unit because 150 sort of feels too much for me. But I've started using Pergoveris in women with low ovarian reserve, that is Poseidon 3 and 4, or aging women with low reserve or young women with low reserve. For the other ones, Poseidon 1 and 2, you get to know only after you've stimulated. So you can add LH either in the second half of your stimulation or in the next cycle. Here, I don't add as 2:1. I add maybe 4:1. That means 300 units of FSH and 75 units of LH. This is what I do, but this is suboptimal according to most of the evidence which is there. Sophia Devi, ma'am, the tests for polymorphism are already available. See, they are available only in the research setting because, Sophia, we also did it with Dr. Rama Raju. We sent when Dr. Mona was working with me, we sent them 20 odd samples where they looked for LH receptor polymorphism, but that was only in a research setting and it had nothing to do about clinical implication. If we have a LH receptor polymorphism, you have to read more about it. I will have to read. It is mainly polymorphism says that the receptor is changed to such an extent that when you give a molecule, it doesn't fit on the receptor. It's not like glove and hand fitting, and hence the effect doesn't come out. So this is what polymorphism is. The more it is mutated, the less will the drug stick on the receptor. So you will have to give a higher drug dose to sort of let the highest number of receptors get stuck to the drug. That is all. So
And
I don't think it should affect the oocyte maturation.
maturation, because HCG is quite a high dose
Yes.
for the polymorphism to
Yeah.
have an effect. Also, I think, ma'am, during the growth of the follicle, the receptors are, they are a different number of receptors. When they're ready to get triggered, I think there will be a higher number of receptors there, and of course, HCG would be a stronger LH source
Yes,
to overcome the
definitely.
polymorphism effect.
Yes. Yes, because it's got a longer half-life. It's got silation of the side chains, which make it longer, and it sort of acts on the LH receptor quite well. So HMG has LH, FSH, and HCG all. So, when this HCG goes on sticking on a daily basis on those receptors, that is when the receptors get blocked and neither LH can act on them, the HMG moiety LH, nor the HCG can act over them. You understand? This is why HMG probably has lesser effect than LH given straight away because it goes on disintegrating within 6 to 10 hours.
Ma'am, Dr. Divya is asking that what if a PCOS patient, we are using recombinant FSH and we trigger with agonist and still get a empty follicle syndrome? Was
Please
it
look
a
at
LH polymorphism?
I don't think that amount of LH polymorphism will not happen if you trigger with, because here there is a natural surge, right? It is not, you're not giving a LH molecule here. You're releasing pituitary LH. So pituitary LH will definitely work. It is the receptor polymorphism. Well, this question is very well asked. I don't have an answer to it. I think that empty follicular syndrome, nobody says that agonist trigger if LH levels are all right in serum done at the time of aspiration are okay, then we don't think that it should be leading to empty follicle syndrome if the levels are good in serum. But yes, maybe we'll come to this theory of yours in future that if the receptors have polymorphism, then even the endogenous trigger surge, high levels of LH will not let the oocyte mature, and it will not separate the oocyte and will not get aspirated in our needle, and it will turn out to be empty follicle syndrome. But nobody has written this till now. It is a good thought process.
It is
This is a
more to do
scientific
with the
mind.
pituitary suppression. If the pituitary is suppressed, then the agonist trigger will not work. It's more like
But
the
if you
endogenous LH
uh,
suppression rather than the LH polymorphism.
polymorphism. So if endogenous suppression by antagonist is not too much, you see in PPOS protocol, some people say that the antagonist, I mean the
Agonist trigger
suppression
does
is
not.
so much that trigger doesn't work.
It
So
has
you are
happened to one of
admitting-
my patients.
Yeah, I know. That's why that is what
Yeah.
I gave the example for, I remember. So, but your Divya question is very good. That maybe one day we'll find that maybe there is some receptor polymorphism, and that is why the trigger doesn't work on these patients.
Right. Ma'am, Dr. Tarang is asking, what do you do for fertility preservation in young patients, like 18-year-olds with sickle cell disease, AMH 1.6, D2 FSH is 10.3, LH 5.6, and E2 33?
You just start them on an antagonist protocol at whatever time they come to you. Suppose she's going to go through some treatment, then you have to start immediately. Otherwise, you can do as many oocyte preservation start like you start on the follicular phase. If sickle cell disease requires you to keep the estrogen levels low, then you can give them letrozole across the stimulation. Go on increasing the dose of letrozole so that the E2 levels don't go over 300 or 400 picograms. So you just do oocyte cryopreservation. That's all. Anything else in anyone's mind, please tell
We
me.
would use a
I don't.
recombinant FSH only for such patients, Dr. Tarang, if that
Yeah,
was.
anything else anyone has in mind, please speak up. I want a bilateral discussion because I don't have answers to all your questions. Like for Divya's question, was it polymorphism? But if your serum levels were good, it should not have been polymorphism. It could be if the receptors don't respond to any levels of serum. But then that is receptor resistance more than polymorphism.
Yeah. Ma'am, Dr. Devanshi wants to know your experience of using a pre-treatment of antagonist for initial 2 to 3 days to get a synchronous cohort. Does it increase the overall requirement of gonadotropin dose?
Devanshi, I'm sorry, I used it for a few patients and I saw no one is using it in the world. So I stopped using it. Plus, I thought, why give these 4 injections to this poor lady? And sometimes if the periods get delayed, then they go on taking it. So that was the reason why I stopped using pre-treatment with antagonist. But I don't think that by using pre-treatment with antagonist, you will require higher dose for gonadotropin. Why? Because you answer, why will it happen? Because antagonist is short acting. It leaves the receptor within half-life is like 20, 21 hours only. So it will leave the receptors. What do you think, Tejashri, Bhavani? Tejashri, what do you think? Will antagonist pre-treatment instead of progenova suppress the gonadotropin?
Yeah, no, ma'am, the dose requirement should not be higher. It doesn't lead to that much of suppression. The antagonist doesn't lead to that much of suppression,
Yeah.
but we all found that the even cohort formation wasn't that good as we found with estrogen pre-treatment. And also the patient kept
Okay.
on taking injections, which was a big hassle for the patient. So we
Yeah.
prefer using a estrogen
Even if
pre-treatment
yeah.
for
Yeah,
cohort
even if
formation.
they leave injections for 2 days during menstruation and then we start gonadotropin, it is the injection part which makes it a little more pathetic. I don't use injections in luteal phase for my patients, except when I have RIF and I have no option, then I use maybe some low molecular weight heparin, but don't use injectable progesterone or any other injections in the luteal phase. Why give these girls so many injections? Yukti.
Dr. Sophia, would you want to unmute yourself and ask the question? We would be happier to listen to you. If you're listening to us, Dr. Sophia, are you there? So
Sophia?
Dr. Sophia says that
She had a
Um,
patient with LH receptor
yeah.
polymorphism,
And
and
she
she
got better mature oocytes when she used only agonist trigger
okay.
rather than having
I gave
Ovitril
Ovitril
plus
plus
agonist.
leupride
This
trigger,
is,
whereas
yeah,
when I gave only agonist trigger, I got. You
that's
see, you
quite
cannot
contradictory.
really pinpoint in a case what happened, because see, when you give a agonist trigger, you are triggering the natural LH surge, and when you give Ovitril plus agonist trigger, then you are ensuring that if by some reason the natural LH surge doesn't happen well, then at least HCG will cover that deficiency. This is the only advantage of giving both of them. And plus, the agonist trigger also leads to little FSH surge, which is another advantage of giving a agonist trigger. So I don't understand that why should it work better and LH receptor polymorphism, if this is there. It is a case report. I think, Sophia, you must report and give an explanation to what you think is the reason that you got mature oocytes when you gave only agonist trigger vis-a-vis a dual trigger.
Ma'am, if you could just again put a little gist verbally about how you choose the gonadotropin in all four Poseidon groups with
Okay.
good reserve and with poor reserve.
All right. So how do I take this off? Okay, this is gone now. Patient C, good reserve, there is no problem. When there is normal reserve, there is no problem. So anyone who has an AMH of over 1.5, please Aram say give them 225 to 300 units of recombinant FSH and they will work with antagonist protocol. You are not using any suppression of the pituitary, except when you reach after day 5 of stimulation, a stage where LH may start rising. You all know that the receptors for LH come on granulosa cells from day 6, 7 onwards, right? And at this time, LH will start working on these receptors and LH will also rise. So at this time, it is important to give antagonist suppression, but this suppression happens like tuck in few hours, but it is not very sustained. If you use a long agonist protocol, then the cohort is very good. You might use a 75 unit higher dose, but you will get a good number of follicles at the end in responders, in high responders, up to almost 1.2, 1.3 AMH. Then comes the group where you have a low reserve. So low reserve is the question where LH helps, because as the reserve goes low, you saw that you need to give more androgen substrate to let more follicles merge up. And LH does that activity, so LH helps here. In advanced age women, the mitochondrial function goes down, and again, adding LH adds the androgen precursor, the growth hormone, and possibly helps better. And the last group is where you get a poor FOE in a patient of Poseidon 1 and 2. Here you can add LH because there could be a polymorphism and or the sort of long agonist protocol may have suppressed the LH-FSH very severely. So very clearly in Poseidon, when you go patients with low ovarian reserve and patients of advanced stage belong to Poseidon 3 and 4, all of them would require some LH in addition to whatever they are getting if they don't respond all right to just FSH. But Poseidon 1 and 2 is the one where possibly there is polymorphism or there is something else, maybe a low starting dose, a low estimation of ovarian reserve. And here you may just increase the dose of FSH or you may add LH according to whatever your mind says. But you've seen studies where only FSH was increased and where LH was added, they got better. So instead of increasing the FSH dose, you can add LH to them if you already were giving 300 units of FSH, because I don't use anything more than 300 units. And acquired deficiency is GnRH agonist long protocol only, and we've done that. And Kohli-Bianiskis sort of refuted that even if LH levels are less than are 0.5 or lower than that, earlier it was 1.2 was the cutoff. but even lower levels gave good steroidogenesis and good follicular development. So please do not use anything in long agonist protocol or antagonist protocol if they are not of advanced stage and if there is no ovarian low reserve. But if there is advanced stage or low reserve patients, LH addition is very good. And if you have got suddenly a low FOE, which happens in group 1 and 2 patients of Poseidon, then also in same cycle or next cycle, think of polymorphism and add some LH to them. So this is my summary in a nutshell. That these are the 4 groups which may require, I would say 3 groups which require low ovarian reserve, advanced stage, and those who suddenly turn out to be Poseidon 1 and 2. There, they could be having genetic polymorphism and add LH and maybe increase the FSH dose by 75 units. That is what I would summarize everything. Agonist, antagonist don't need if they are normal, not advanced stage and not low reserve patients. They don't need any addition of LH. Is it enough to summarize? Is it understandable?
Yes, ma'am.
So these 2 lower ones are the most important where you need to add LH, especially if you've started only FSH and after 5 days you find a poor response. And Poseidon 1, 2 तो हमें इत्तेफाक से मिलता है only when we stimulate. Usme you can also think of increasing the FSH dose in the next cycle, but adding LH can be done in the same cycle. Increasing FSH dose in the middle of the cycle hardly helps you because already recruitment has happened. Increasing FSH dose in the next cycle, but you can add LH in the same cycle to increase the steroidogenesis and the growth of the follicle.
Ma'am, one last question that we'll take is there any indication for minimal stimulation protocol?
I don't really do. I'm not a proponent of minimal stimulation. I feel that, the patient is spending everything with IVF, and if we keep her hanging that in 30% we'll have no oocyte retrieved, it doesn't appear fair to me. So I'm sorry, I am not a proponent, but a lot of people are doing it in the world, and they feel that there you must not charge for IVF at all then. Just get a needle, aspirate that one follicle, and see if you get a oocyte, okay. If you don't get a oocyte, forget everything.
Ma'am, Bhavani here. Ma'am, what is your opinion on role of HMG in PCOS? There was a large trial megaset which said that the pro-apoptotic effect of HCG may help in preventing OHSS by
Correct.
causing
Very,
apoptosis.
very correct. It is, you're right. In megaset trial, this was it, the pro-apoptotic effect, because it leads to more apoptosis, and therefore maybe OHSS doesn't happen so much in those patients. But we have crossed that phase now. We have gone past through that effect that we can segment our cycles, we can prevent OHSS fully. So HMG has very inconsistent effect. This is my only thing against. Give a lower dose of FSH alone. Don't give HMG. OHSS was a big threat when we were doing fresh transfers, when we didn't have vitrification, when we could not segment our cycles, when we did not have agonist triggered. But now megaset trial was published now, and it took consideration of studies which were from 2000. So I agree that you give HMG, then it has got such inconsistent effect that sometimes the pro-apoptotic effect or HMG itself will not lead to OHSS because the response is on the lower side. Am I correct or no? You tell me something else, Bhavani.
Yes, ma'am, I agree.
You agree,
With,
na?
with segmentation and agonist trigger and segmentation, we are quite safe in preventing OHSS.
Yeah,
it's better to get a good response rather than get a poor response and prevent OHSS.
Even the robust
Since we started
vitrification.
segmenting and freezing, we have not seen any OHSS because the moment we take out 15 or more oocytes, our regime for OHSS prevention starts. It is on the day of OCR only we start giving them HES, give them something like a dopamine agonist, maybe also give them maybe an antagonist dose 1 or 2, 3 days to immediately suppress the pituitary FSH LH, and things do work out. Where
Thank
was
you so much, ma'am. We have discussed all the questions. I am sure we'll have more questions. We can have them on the WhatsApp group that we've made. Always welcome to share your thoughts and questions on the
I
WhatsApp
want
group as well.
everyone to share their thoughts. I want to learn from you all also. It is becoming a one-sided learning by you not contradicting and bringing in evidence. So this is the slide, Bhavani, if I don't know whether you missed it, but as you said, the pro-apoptotic genes, HCG and FSH has a pathway which produces this and causes a pro-apoptotic effect. And this is why OHSS becomes less, but even the stimulation goes lower with this. Even the oocyte formation and possibly number of collection might go lower. But we'll have to go into this details of the trial, the megaset trial. Okay, thank you.
Thank you so much, ma'am. As always, we really appreciate and your efforts that you take for each lecture. And we learn so much every time that we all are enriched after each lecture. Thank you so much, ma'am. And thank you everybody
I'm
for
very
joining.
glad that you all have questions. If you don't have questions, the day I find no questions on the chat box, I'll stop the masterclass. So I'm only having it because I want all of you to ask, and you can unmute and ask also. Very important to do that. Thank you,
Ma'am, your
Vishal.
life lessons have been hit
Thank you, ma'am.
now, and I think next time we must have a slide for the life lesson as well. And
Yeah,
have
yeah,
shared
yeah.
some
This
thoughts
time I
with
couldn't
you.
make one, but I made that seesaw wala slide. Then you have a heavier problem, you need heavier drugs. When you have a lighter problem, you need lighter drugs. So when you have no problem, normal responder, high responder, you use only FSH. But the moment advanced age is added, the moment low reserve is added, the moment a genetic polymorphism is added, you need more drugs to overcome them. That is a simple rule which I want all of you to remember. Right, Manav?
Yes, ma'am. Thank you very much for such an
Yeah,
interactive session.
yeah, I know you were sleeping. I saw that, so don't worry. I'm
I
sure you
was
were
there.
sleeping. Yeah, you were there. Thank you so much, everyone, for joining and giving me this encouragement to continue to read and present. But please contradict, please give your opinions. And on the chat box, I want this to become a very active academic chat box. Give your opinions. And if you find anything, Bhavani, about the Megaset trial, write the details. So we'll get to know what did HMG do vis-a-vis LH. Okay?
Yes, ma'am.
All right. Good night. Bye.
Good night, ma'am.